Well, we've talked about depression and you learned about diabetes. Let's talk about what happens when the two come together. So, interestingly, diabetes increases the risk of a major depressive episode twofold. Um, Unlike my example of obstructive sleep apnea or a brain tumor, there's no known causal relationship that exists between diabetes and depression. There are some biological links that we are going to explore, but one of the most important things I want to convey to you is that when present, major depression complicates the prognosis of any medical disorder, including diabetes. Now, when you consider diabetes is the seventh most common cause of death in the United States, and depression complicates the prognosis, you can see that we're talking about very, very many people with both conditions who have a worse prognosis because of the combination of these two diseases. So the first thing I want to talk about is the bidirectional relationship. I hope it's bigger on your screen than it is on mine, but in any case, Part A, these are just a whole bunch of different studies. We call this a meta-analysis, where the results of multiple different studies are all added up, and we look at the bottom, what's surrounded by a yellow circle, and that's the sum of all those studies. So Part A shows the risk of patients who have depression getting diabetes later in their lives, and Part B looks at people with diabetes getting depression later on in their lives after they've already been diagnosed with diabetes. And since both points are to the right of unity, which is that vertical line, it means that indeed sometimes depression comes before diabetes and sometimes diabetes comes before depression. So it's a bidirectional relationship. It's not just that you get depressed because you have diabetes. It can go either way. Now here's a small study looking at the odds of depression in patients with diabetes. So diagnostic interview just means that an expert interviews the patient, and in this case, 9% of the depressed, 9% of the individuals with diabetes met criteria for depression compared to only 5% of non-diabetics. If you give people their self-report scales, like surveys that check for depression, you'll see that in this case, diabetics scored 26% scored positive for depression versus only about 14% of non-diabetics. So essentially it looks like there's about twice the risk of depression in someone with diabetes. Now, how does depression affect diabetes? Well, this is the big deal. You look at the hemoglobin A1C, which is a measure of 3 months blood sugar control, and you see that trying to control for every risk factor you can, you still see that depressed diabetics have worse control of their diabetes compared to diabetics without depression. And unfortunately, not only do they have worse glycemic control, but they have a greater risk of complications from diabetes. And here you see a study done on mortality rates. Now, up here is all-cause mortality. In patient or an individual with no depression, no diabetes has a mortality rate of, say, 19 per 1,000. The patient doesn't have diabetes but does have depression, now there it's going to go up by 30% to a mortality rate of about 25.7. Now what if they have diabetes but not depression? Well, it goes up a little more to 49 per 1,000. And then if you've got both, it goes up to 70. Wow, so you can see the synergistic effects of depression and diabetes on mortality. And of course, the most common cause of mortality in diabetics and in depressed individuals is coronary artery disease or coronary heart disease, and you see that this trend exists as well as you come closer and closer to having both diagnoses. Your risk of dying from a heart attack or even having a heart attack is increased. Now, I think we learned earlier in our cardiovascular section that depression poses an independent risk on mortality after a myocardial infarction, and that lasts up to 5 years after the incident myocardial infarction. And each of these lines refers to severity of depression, when there's really no depression versus some depression versus quite a bit versus severe depression. You have lower and lower mortality, higher and higher mortality rates as the depression ratings are higher. So this is true with many conditions, including diabetes and heart disease. So how does depression increase these medical complications? Well, some thoughts are, well, there's poor adherence to medical recommendations. These people don't exercise. Depressed people may eat too much and may eat a diet rich in carbohydrates, which impairs glycemic control. Depressed people may become obese and not do anything about it, and that certainly can exacerbate diabetes as well as all kinds of medical complications. But even when we try to control for all these factors, the mortality in depressed diabetics is still greater than it is in straightforward diabetics, even when you control for these risk factors. So what it means is that we don't really know fully why the combination of depression and diabetes is so lethal. We do see some pathophysiological linkages between these two disorders. And when we discuss depression later on in the year, we'll talk about all the various biomarkers. But here I'm going to talk about two that are common to depression and diabetes. The first is the neuroendocrine hypothesis, in which there's abnormal activity in the hypothalamic-pituitary and adrenal axis that controls secretion of cortisol. In depression, this abnormal activity leads to a tonically increased state of hypercortisolemia. The other physiological variable that connects depression and diabetes is that in both conditions there's elevated markers of inflammation. So C-reactive protein, certain cytokines like interleukin-6 and tumor necrosis factor alpha are elevated, and leading experts to say that both depression and diabetes are indeed inflammatory conditions. So let's talk about this abnormal hypopituitary adrenal axis. So up here you got the hypothalamus. It sends the hormone corticotropin releasing factor to the pituitary gland, and then the pituitary gland releases corticotropin, which then goes to the adrenal gland and tells the adrenal gland, hey, it's time to make cortisol. Well, that's very good. In fact, in a normal situation, the adrenal gland goes ahead and makes as much cortisol as the pituitary gland is telling it to make. And then as the cortisol goes around into the bloodstream and back into the brain, it suppresses the hypothalamus from continuing to release the corticotropin releasing factor. And what this does is it keeps cortisol levels in check. Too much cortisol, not good, because it's been shown that hypercortisolemia can cause hyperglycemia. It can cause osteoporosis in the long run. It can actually cause the hippocampi to shrink, leading to an increased risk of dementia. And these are conditions that we actually see in diabetics. So this discusses, this kind of just talks about the negative feedback loop and how it's absent in depressed patients. So in depressed patients, there's excessive production by the hypothalamus of corticotropin releasing hormone and eventually elevated levels of cortisol. And so many seriously depressed people have high blood levels of cortisol, which is caused by chronic stress. As you know, cortisol is considered a stress hormone. So Hypersecretion of cortisol is found in 50% of depressed patients. And then there's this test called the dexamethasone suppression test. That's when you give people a steroid, in this case dexamethasone, give it to them at night, and in the morning you see what their cortisol blood levels are. Now normally giving an exogenous steroid will suppress release of corticotropin releasing factor from the hypothalamus, and so the next day you'll see low levels of cortisol because that negative feedback loop worked. However, in 50% of depressed people, you give them dexamethasone, and the next morning they're still making all the cortisol in the world, which shows that there's a big abnormality in this system. This kind of problem in the hypopituitary adrenal axis is not specific to depression. It can also be found in other conditions as well. So don't get me wrong, steroids are wonderful things. We give prednisone to people with asthma exacerbations, it works wonderfully. We give it to people with flares of rheumatoid arthritis, etc. And they actually can lift mood as well. But the reason why we can't give cortisol or prednisone, etc., to our patients long term is that there are a lot of complications. So elevated cortisol levels cause hyperglycemia, and you'll have people on prednisone, for example, who develop de novo diabetes just from the prednisone. Hypercortisolemia is a risk factor for atherosclerotic disease. So give people prednisone for years and you're accelerating atherosclerosis. Steroids also demineralize the bone, long-term complication of osteoporosis, and there's evidence that steroids shrink the hippocampi, the main areas in the brain involved with memory, and again that can be a long-term consequence of steroids. Now, another link between diabetes and depression is inflammation. Depression is associated with increases in several inflammatory factors such as C-reactive peptide, interleukin-1, interleukin-6, and tumor necrosis factor alpha. And lo and behold, the same inflammatory markers are associated with type 2 diabetes. These are all called cytokines. And we know clearly that cytokines cause symptoms of depression. One of the well-known drugs to cause depression is interferon, and interferon increases level of cytokines in the effort to kill the hepatitis C virus. In any case, unfortunately, these cytokines also cause symptoms of depression. So depression, in addition, cytokines can also increase insulin resistance, which can predispose to type 2 diabetes. What comes first, what comes second is unclear. Patients with pancreatic cancer, for example, well before the diagnosis of pancreatic cancer, can come up with symptoms de novo of depression that they never had prior. And we think again that that's the inflammatory markers that are causing the depression. So we've talked about how there's a derangement in cortisol and an inflammation that can link depression and diabetes. We've also talked about how depression vastly increases the risk associated with diabetes in terms of blood sugar control, medical complications, and even mortality. So obviously very urgent that we find something to help people because depression and diabetes are ubiquitous in our country. So turns out that antidepressants work just as well in diabetics as well as they do in non-diabetics. So we know for sure we can help these people who are depressed. The studies, unfortunately, are mixed on whether treatment of depression improves diabetic outcomes. So some studies say yes, some studies say no. A lot of them are flawed because they didn't have enough participants to really detect differences in diabetic outcomes. And of course, you need a lot of time after you've treated the depression to see if diabetes improves or the complications are diminished, and very few of these studies follow diabetics long term. So anyway, we don't really know the answer to that question. Nonetheless, as I said, most antidepressants are effective. Psychotherapy has virtually no side effects other than having to pay for it and having to take out an hour or two of each week devoted to it. But then you've got drugs, which of course do have side effects. And I'm just going to mention two. You're going to learn all about these when we discuss psychopathology later in the year. In any case, bupropion, which is also Wellbutrin, is in a way an ideal drug for depressed diabetics because it's not only an antidepressant, but it also promotes weight loss. In fact, it's half of a compound that's FDA approved for weight loss. So this could be very beneficial for two issues, depression and obesity. Unfortunately, Wellbutrin is not all that great with anxiety, and many depressed individuals and depressed diabetics have concomitant anxiety. Another antidepressant that may have a role in treating diabetes is duloxetine, which you will know as Cymbalta. This drug is FDA approved not only for major depression, but also for diabetic neuropathy. So both bupropion and duloxetine are two antidepressants that we think of when we are treating depressed diabetics. But again, all of these drugs, all antidepressants, including SSRIs, are effective for depression as well. So putting this all together to our case of Gloria Lopez. So this patient has had a major stressor, which is a divorce, and major stressors put people at risk for having a major depressive episode. She does acknowledge difficulty sleeping, has an increased appetite with weight gain, guilt about the divorce, decreased pleasure, and decreased concentration. Fortunately, she's not suicidal, but she does meet the criteria for a major depressive episode. So her depression might be contributing to poor glycemic control, or vice versa. As we've talked, it's a bidirectional relationship. She has dermatologic and neurologic consequences of diabetes. She's got fungal infections in her feet, and she's got peripheral neuropathy. She also has obesity, which is a cause of diabetes, and it can lead to obstructive sleep apnea, which she also has. And what do you know, obstructive sleep apnea itself can cause depression. So it's a vicious circle of obesity, diabetes, depression, sleep apnea, etc. So what are we going to do for her? Well, in addition to improving diabetic control, her depression must be treated. So for her depression, we might offer psychotherapy or antidepressants, the two that I mentioned to you, bupropion and duloxetine. And again, we need treatment of her sleep apnea. We could also consider a drug that we talked about in relation to eating disorders, and that would be Vyvanse or L-dexamphetamine, which can decrease any binge eating that she does. Of course, we'll have to watch the blood pressure because she has hypertension, and amphetamines can raise blood pressure. So, conclusion, the rates of depression in diabetics are twice that of the general population. It's about 10% versus 5% in any given year. There's a bidirectional relationship. Depression leads to impaired glucose control, increased complications, and mortality rates. Inflammation and hypercortisolemia in depressed patients may partially explain the link. Antidepressants are equally effective in depressed diabetics versus non-diabetics. And there's mixed evidence that treatment leads to a better prognosis for diabetics. Certainly, the jury is still out, and we hope we'll find an answer in the coming years. Thank you.